Hello, hello, hello. Happy Friday. Happy Friday. We made it through the week. Happy Friday. Is anybody joining me? Let me know if you're joining me so I know I'm not on my own. Because today I thought it would be really appropriate to put in here birth preferences, because it's a huge part of my job. I've got a little doggy nose poking in. Hello. It's a huge part of my job, and it's been a little bit tricky, a little bit different. Sometimes we have to do this, a big part of this over the phone. Obviously we can't do your physical check over the phone, but it's nice to see your face. What? Can you not push the door open? Hang on, let me let the dogs in. Let me let the dogs in. I was locking them out, but they want to come in. Are you coming in? You can come in. Just... Ooh! So, I don't... Is anybody with me? Anybody with me? I've got my candles on, and I've got my aromatherapy lamp on there. And first of all, while I'm waiting for y'all, I just want to say I had a really, really, really exciting package. The postman brought this, the Proud Midwife, and it says on it fragile. So first of all, I could hear, and I'm thinking, I'm not sure what that sounds like, but it sounds like broken crockery. So I'm like, oh, the beautiful and gorgeous, kind, generous Becky from Maternity Voices Partnership has sent me. I'm very pleased to get my replacement Bay Wide Maternity Voices mug, and I've got my tea today, which is called Peace. And I'm so glad she sent me 4, because 2 of them have survived, and unfortunately 2 of them got a little bit, just the handles broken off, but I think they look like clean breaks. I think I'm going to be able to glue those back on again. So thank you so much, Becky. That's so kind of you. Not only did she send me 4 mugs, she sent me 2 lots of tea. That's so thoughtful of you, Becky. Thank you so much. And I've got a handful of Maternity Voices pens, so I'm going to keep one for myself. And next week in my clinic, I will be giving some of those out to my very wonderful ladies. I'm back at work next week, so I'm looking forward to catching up with some of my ladies. And if I've got any left, you can have a pen. And really kind and thoughtful card that came as well. Oh, so thoughtful. Thank you so much. That really made my day. It was really special. And now you see, I'm going to try not to break another one. Okay, shall we get started? Amy. Hi, Amy. Thank you for joining me. So, one of the main challenges that we've had while working through this year, the coronavirus pandemic, is we've had to, just like a lot of other places, but even more so in the hospitals, we've had to introduce lots of safety measures, we're doing lots of cleaning, so it takes us a little bit longer, so just bear with us if your appointment's a little bit delayed, because we are doing an awful lot of cleaning. A lot of this stuff is getting used, a lot of the alcohol hand gel, and if you choose to have your baby at Lancaster, you'll be able to see where I've put the red circles. You can see there is, they've got a one-way system, keep left, you'll see all those, but we've got there the hand sanitizers that they've got, and that's the entrance, well, what you'll see when you walk through delivery suite doors, and you'll be shown to your room. But we'll come on to everything on this birth preferences list. For my ladies, I always give them a copy of this. I've put, it just says birth preferences for birth, and it's got a bit of helpful information on the back. But this is just the list that we go through, the checklist of things to discuss with you and talk to you about. So for your birth preferences, it's trying to get you to think about some of the things that you might be asked to make decisions about. But there are some online templates as well that you can find. You can find a whole host of them where it's sometimes good to record your thoughts, and if there's anything you feel very strongly about, for example, if there's any cultural preferences that you want to tell the midwife about. So that's what I'm going to go through. But the first thing to let you know is things are a little bit different when you go into have your baby, and that is, main thing is all the PPE. So I'm going to show you the basics that we have to wear. So we should always be using our gloves. So we're going through a fair few pairs of these, so we'll have gloves on, and we'll also have a plastic pinny on. So sometimes when you press your buzzer for a midwife or health professional to come in, and because you need something, sometimes it takes a little bit longer, because outside every room on the ward we're having to change all this every time. So we're not ignoring you. It just sometimes takes longer, and lots of hand washing. So we have to have this on. Obviously, the midwife will have a midwife's uniform on. And this funky thing. So we've got this on. And if you're a bit more sensible, you put your mask on before your face visor. So this is how the midwife may well look all the way through your labour. So there's lots of changing. There's also a whole new set of things that we have to wear if we need a sterile field, and we have sterile gloves and things like that for examinations. So I'm going to take all this off. So it's odd. This year is odd because we're looking a lot like this. And that's why I like doing these lives. I like doing these lives because you can see my mouth. So let's take off all this. So that's what we might be wearing, and lots of changes, so bear with us. And I just wanted to quickly signpost you towards Maternity Voices. I've put a link on my page. And I've just got the website up on my computer here. What is the Maternity Voices Partnership? Well, I'll tell you. The Maternity Voices Partnership is a forum for maternity service users, providers and commissioners of maternity services to come together to design services that meet the needs of local women, parents and families in the Morecambe Bay area. So it's such a valuable resource, and your experiences and your ideas, and if you've been in hospital or you've been in delivery suite and you think there's something that was really good or something that you think could be improved, we'd really like to know. And it's, as it says on my cup, have your say. Because if you're a service user or family of service users, we all want to be good. We all want to give you a good service, so if you tell us, we're quite happy to try and change things, to adapt, to listen to what you say. So let us know. Okay, so you've got lots of cleaning, lots of hand sanitizers at the moment, and anybody who's watching, if you've got any ideas, or correct me if I'm wrong, but last time I worked on Delivery Suite, on Delivery Suite you just allowed one birth partner at the moment rather than the usual two, and you will both be offered coronavirus test when you get to the hospital, and there are some more restrictions upon the ward, so partners are not allowed to stay on the ward at the moment. However, your partner is allowed to stay with you if you're having an induction of labour, and we'll talk a little bit about induction of labour when we get to it on my list. Okay, and I've got you some bits and pieces just to show you some of the things that you might encounter. Hi Lisa. Right, on my list, so where to have your baby. So you need to choose it's your choice where to have your baby, but there are some bits of advice that might point you towards one location rather than another. So you could have your baby at home if that's what you wanted. Speak to your midwife or consultant about whether that is the best place for you, because sometimes if you've got lots of different medical conditions or extra needs, it may be more appropriate and safer for you to have your baby in hospital where there are different professionals that you need for your care. So speak to your doctor or your midwife about where you want to have your baby. So we've got home, maternity unit. So in this trust we have Helm Chase for our low risk ladies, and they have such a nice, they've got a huge pool room, they've got a home from home room, and if you want to have your baby there, then they can give you all the details about the numbers to phone for if you go into labour in the night. And the other one is either Lancaster or Barrow. They are consultant-led units, which means that rather than at Helm Chase, the midwives will look after you there. At Lancaster, the midwives will still look after you. However, we have the doctors and theatre staff and the neonatal doctors are all based in the consultant unit in the hospital. And they don't necessarily need to come in and take over your care from the midwife, but they're there if we need them, and they will usually come round on ward rounds just to make sure that you are getting the right plan of care for your pregnancy and labour. Okay, so where to have your baby, that's first on the list. Intended length of stay is the next thing on my list, and intended length of stay can differ depending on what sort of birth you have or whether your baby needs any observations after delivery. So some of these things are predictable, and it might be because baby needs observations because of mum's on a certain type of medication through pregnancy, or baby's particularly small, or there's something else that comes up that wasn't expected. For example, some babies need blood tests for jaundice, so the yellow tinge that the skin goes. Sometimes we need to do observations and blood tests to check that the levels of bilirubin are at safe levels and they don't need any extra treatment. That's usually the phototherapy, which is like a sun lamp, UV rays that are measured to be safe for your baby for the treatment of jaundice. So not all babies with jaundice will need phototherapy, but some babies do need a little blood test to just to check everything's okay. Some babies will need routine observations, for example, if mum's had any risk factors for infection, either in pregnancy or in labour, so that maybe that's a high temperature, or the midwife will be able to tell you what the further testing or further observations are for and what the reason is for it. I'm just checking that candle up there. It's going for it, isn't it? I'm just checking it's not setting anything else on fire. So, intended length of stay. At the moment, obviously with all the coronavirus restrictions, we don't want you to stay in hospital longer than you need to. So speak to, before your birth, in labour, after birth, ask the midwife how long they anticipate the that you're gonna be staying in hospital for, and hopefully they'll be able to give you a little bit of an idea. Right, okay, so and obviously it depends also on what sort of birth that you've had. Hiya Faith, hiya Zosha. The professionals are watching me. Feel free, peoples, to correct me if you notice me making any mistakes. Okay, so obviously it's a little bit different, your length of stay, depending on what type of birth you have. So if you have a normal birth that's nothing uneventful's happened and every mum and baby are happy and healthy, then potentially you can have a 6-hour discharge from hospital. If you've had a little bit more bleeding than we would like, and when you have your baby, they might want to do, the medical professionals might want to do some blood tests for mum after baby's been born, and just make sure everything's all right. Make sure your pulse and your blood pressure and everything like that's okay before you go home. And if you've had a cesarean section, it's major abdominal surgery. You're not going to be going home in 6 hours usually. So all these the times that you will stay in hospital is intended to keep you in hospital for the least time possible, to keep you and your baby safe, but as long as you need. And there are other considerations. If you need help with breastfeeding, the midwives can help you with that, because we want to send you home feeling confident, and you ask your midwife about FAB breastfeeding support, because they can help you once you go home in the community. So what to bring? I never go into this in too much detail because there are so many online lists you can access what to take into hospital. It's really not rocket science. However, babies don't need loads and loads and loads of stuff. Babies usually are dressed in a vest, the little vest that poppers underneath, a baby grow. And for the first day, baby has a hat on, but just for the first day. And bear in mind, the first day your baby's born is considered by us to be day 0, because your baby is not a full day old until 24 hours after baby's born. So we class the day that your baby's born as day 0, which I know it's a little bit odd. So what to bring? For mum, pretty much big comfy knickers, pads, comfortable clothes. Have a think about whether you want pajamas or a nightie, because if you're having a cesarean section, a lot of the times a nightie is a lot easier for you than pajamas. It's just easier to slip on. Towels, things like that. For baby, what we recommend is cotton wool and water to clean baby's bottom. It's really nice to have lovely smelly wipes. They smell lovely because the manufacturers want the mums to buy things that smell nice. But if they've got lots of nice smelly things, they have generally got chemicals and perfumes in them to make them smell like that, which sometimes a brand new baby, brand new skin, the kindest thing is just water, just cleaning it with water. So just a plastic dish, cotton wool, and just lukewarm water to clean baby's bottom. Lots of people ask me, when can I bath my baby? When can I bath my baby? So when your baby is born, you'll notice that usually in the cracks of their arms, creases around their necks, there's a kind of a very thick, it feels a little bit waxy. It feels thick and waxy. That's called vernix, and that is the baby's beautiful natural waterproofing. So when your baby's in your tummy, just swimming about. You know, the white vernix is what protects their skin. So what's a little bit of a shame sometimes if parents want to wash it all off really quickly. Obviously, if your baby's got blood in the hair or anything like that, you can just gently wash it off, but with water. So, you know, I wouldn't recommend a brand new baby using lots of soaps and smellies. The kindest thing is water. But you will see in lots of shops that people sell brand new baby stuff. It smells beautiful. I'm sorry, but the kindest thing to put on your baby's skin at first is just water and dry baby, obviously, after you've bathed your baby. But there's no need to bath a newborn baby immediately after it's born and every day. You know, they don't need it. I mean, it's different if they have a really dirty nappy, then that's a different story. But as long as they're clean, they don't need an awful lot of bathing. Right, okay, and just remember, nobody makes money out of selling you water. No one makes any money out of that. But we hopefully can advise you on what's the right choice for your baby. Who's going to be present is the next on my list for delivery. We've already talked about restrictions on visitors. It's really tricky. And sometimes it might seem a bit cruel and like you're just not getting the support. The midwives, please ask the midwives if there's anything we can help you with. Or any advice. No question is a stupid question, and we do know that you might not have your mum or your sister who's just had a baby or your friend who's had a baby. You know, we know that they might you're not getting to see those people at the moment who are your support. So we do understand, we do really understand that it's a tough time and you don't have lots of those support mechanisms. So we're coming to work. We might have to wear all the gear, but we're coming to work, and we do appreciate sometimes it's quite busy on the wards because, you know, babies just born when they're ready to be born. So sometimes it's really busy on the ward and sometimes it's very busy on delivery suite as well, but it doesn't mean that we don't care. And what happens when you're really busy, especially on the ward, you're trying to prioritise things. So you're always trying to do the job next that's most important. And sometimes it takes you a little while to get round to people, but it's, you know, and sometimes we do forget. So if you've asked a midwife, you know, could you have a towel, and then just 3 hours later you still haven't got a towel, it's just because it's slipped our mind. It doesn't mean that we think you cause you any trouble and we don't mind getting, but I might just only be talking from my own experience, but I forget things like that because you're thinking I need to do the baby observations at such and such a time, and sometimes things like towels and pads and things like that, sometimes you forget about them. But it doesn't mean we don't care. It means that sometimes we get a little bit forgetful if we've got a lot of things to think about. Hi Danielle, how are you? Got midwives. What if you've got anything to add, ladies, please do add, and if you think I've missed anything out as well. So we talked about who's present, and we've talked about COVID testing as well. And one of the things you might get asked about is if you're happy to have students present. So obviously our student midwives do need to carry on with their training. It's really important. And at Lancaster, I can only speak for where I work, we've got some such wonderful students, and very often people get a little bit fearful about having students because they think students are going to be standing in the corner watching them when they're at their most exposed, their most vulnerable, and they're going to make them feel really uncomfortable. And the truth is that the student midwives are well supported by the midwives, so you would never have a student midwife looking after you on on her own. She's always supervised by a qualified midwife. However, they can offer you a lot extra. You know, it's 2 people to look after you. A lot of them have already delivered lots of babies under supervision. A lot of midwives, student midwives, have their own children, and a lot of experience as well. And you know, they can be a really, really valuable extra support. And if you agree to having students and you say you're happy for them to come into the delivery room and you just freak out and change your mind, one of the things I always tell my ladies is okay to change your mind. It's all right to change your mind. You just, so if you say, yes, I'm happy to have students, and you've said it and it's been documented, you know, and you're having a massive panic attack because you've decided that that's not the right thing for you, it's okay to change your mind. And the students do understand. But the students are a really good help for us as midwives and for the new mums, and they can help you with so many things on the ward as well. So, you know, if there's students about, make use of them, and they're often such a good emotional support, as well as practical things like, you know, helping you with baby and, you know, showing you how to do things. Hi Shona. Okay, so you might be asked about students, and it's your choice. It's your choice. I'll try and drink my tea before it goes cold. Okay, signs of labour. Signs of labour. What do you know about signs of labour? Well, what do we know about signs of labour? So you can access... Hi Colette. Signs of labour. Everybody experiences labour differently, and for some people, it depends on people's own pain threshold and usually how calm they are as a person. So lots of ladies that cope really, really well in labour are those people, you know, that are just calm. Just calm. I'll deal with it as and when it comes. Don't worry about things when they haven't happened. But signs of labour, basically what the uterus does is it takes a bit to get going. It takes a bit. So you might have had some Braxton Hicks, which is where you're not in labour, but the uterus squeezes and you can feel your tummy. Your tummy feels really hard and then it relaxes. If you get any unusual pains that are continuous, or any bleeding, or any of those symptoms that you're worried about, you will have, this is what we have at Lancaster, you know, your blue card. There are phone numbers on there, so you've got the hospital numbers on there, but you've also got the ward number, you've got day assessment unit, delivery suites phone number on there. So what we don't want you to do is we don't want you to sit at home worrying about something. You can often I say to people, if you don't know who to phone, just phone any of them, and they will always point you in the right direction. But if it's just a simple query that's causing you worry at home, just ask someone, and hopefully we can give you an answer that will put your mind at ease. Okay, so signs of labour, basically what the uterus does is it sort of has a bit of a squeeze, then it stops, then a bit of a squeeze, and it's a bit what we call irregular at first, and that is perfectly normal. So very often in the early stage of labour, very often the most appropriate place for you to be is at home. And the reason for that is labour can be, in the early stages of labour or the latent phase of labour, very often contractions are a bit on-y and a bit offy. So you might have, the way I describe labour as starting is you may just have had a bit of an unsettled night. So you're a bit tossy, a bit turny, didn't really sleep properly, but you were fine. You weren't in a lot of discomfort, a lot of pain. but you're just a bit unsettled. Then through the day, you might have what just feels like a little bit like period pains. You might get lower sort of backache, but you're fine. You're fine. If you go into labour, you don't need to panic. If there's any reason that you need to go into hospital immediately, if you go into labour, and some of the reasons are if you're planned for a caesarean section and you go into labour, Delivery Suite likes you to contact them as soon as you can, or if there's anything concerning you that you don't know about, like if you should always call Delivery Suite if you think your waters have gone or you're not sure, but we'll come on to that in a minute. So the uterus will just start to have a little bit of a squeeze. So people don't just go into labour and then a baby comes out like they do on the telly, like they do in soaps. They have 2 contractions and then the baby's born. It very, very rarely happens like that. It generally, the more after your first baby, usually the labours are a lot quicker. Usually if it's your first baby, usually first labours just take a little while to just get into a rhythm. So bit of backache, and then you might start to think throughout the day, well, these do feel like contractions because I can really feel that they're starting to become a bit more uncomfortable. And I always say to women, very often you can tell how you're getting on by how huffy and puffy you are. And what I mean by that, and this is one thing I've really missed, my impressions. I usually do my impressions, but I can't do them with a mask on. So a bit huffy and puffy. So you might be going through your day and you might notice your breathing gets a little bit heavier. In a normal day you don't really tend to notice your breathing, but you might start to notice that when you're getting these tightenings, you're needing a little bit more oxygen, so you're noticing your breathing get a little bit deeper. But you're okay, you're carrying on your business, you might want to go for a walk, but you think, I'm getting excited now. That's the bit to get excited, when you think, is this the day I'm going to meet my baby? So contractions generally start to get a little bit stronger, and then they start to get into more of a regular pattern. So I don't know whether you ladies have ever been in hospital, the CTG machines that record the uterine action and baby's heart rate, and it comes out on like a graph paper, and it shows us baby's heart rate at the top, and then it shows us the strength of the contractions or the uterine activity at the bottom. So if we were to put somebody on a monitor in very, very early labour, I've got nothing to draw it on here, have I? Let me see. So in early labour, this is what I draw for my ladies. Lots of people have seen these, but can you see that? That picking up, you might get some contractions that you might say, oh, well, that was really intense, I felt that wasn't really much. And then you go like ages without anything, and then you get, oh, a little one, and then you go, oh, that was a really big one, oh, that was a really big one, I could really feel that. So you can see that the contractions are quite irregular. So one of the ways I say to people, you might be able to tell if they're irregular contractions, is if the time between each contraction is all different. So you might have a gap of 5 minutes, 2 minutes, 20 minutes, 15 minutes, half an hour, 2 minutes, and you can see that the uterus is just trying to get itself into a pattern. And then sometimes what happens is you start throughout the day thinking, yes, I am, today's the day, I'm feeling contractions, I'm going to ring them up and I'm going to have my baby today. Sometimes what can happen is all the contractions just settle down and go away. Sometimes they go away completely. That's normal and that's fine. Don't forget all this stuff that I'm telling you about. Don't forget, you should have got a leaflet that tells you important symptoms to get checked out. So I'm just telling you about if everything's normal, but that symptom checker, or if you're not sure, you can phone delivery suite or day assessment unit. But as long as you think everything's normal, you're all right to stay at home, because as soon as you start getting contractions, if you go straight into hospital, we just don't know how long that initial latent stage of labour is going to last. And sometimes it's a couple of days, depending on woman to woman. And sometimes you get that happening. You start getting some contractions and then they all settle down and go. So I don't want you to think that you're going backwards if that happens. That's normal. It's fine. If that happens and you've been getting little sort of niggles all day and then everything just settles off in the evening, have some rest. Take your time to just do some of the relaxation techniques. And that's really kind of your body to give your body a little bit of a chance for a rest. So it's perfectly normal. If there's anything that you're not sure about, you can always ask. I'll have a little sip of my tea. So contractions. As contractions go on, they, as a general rule, excuse me, as a general rule, they ask you to go into hospital when contractions are every sort of 5 minutes, and they're coming regularly. So the timing in between is 5 minutes. So that's a good sort of guide. But if you're really not coping very well, or you've got some horrific pain that you're worried about, or any other concerns, you can just ring them for advice. And sometimes what ladies will do is they will ring delivery suite and just have a chat to a midwife, tell them how they're getting on, and the midwife can take down your details and say, I've got Mrs. such and such, she's phoned this afternoon. And very often the day shift will hand information to the night shift, so they can, the day staff might have taken down some of your details, say, well, Claire's at home, she's started in early labour, but she's comfortable at home, she's okay, but here's the details. She may well be giving you a call in the night when she feels ready to come in. And a lot of women choose to go into hospital when they feel they need some extra pain relief. So they just want some, might want to use the Entonox gas and air. So contractions. So generally, let me do you another little diagram. Generally, and it doesn't look exactly like this. It's a bit more jaggedy than that. Generally, at the time when you're ready to push your baby out, if we look at the monitor, the contractions on the monitor look a little bit more like that. So you might get 4 intense contractions in 10 minutes. Generally, that's how many people get when they're getting ready to be able to push their baby out. And these contractions are really, they've got to their sort of most intense. So the uterus is really, it's got a big job to do, that muscle. So it's really squeezing down because it's got to squeeze a baby out. But those contractions really feel quite intense. They feel quite intense. But there is some good news, right? So this is sort of your contraction to the peak, and then it starts to settle down. The good news is that this bit in between, there is no pain. No pain. The uterus has completely relaxed, and that's your body saying to you, okay, let's get it together now. Let's get ready for the next one. And this is the time where I say your body is giving you a rest. So that's the time where you want to drop your shoulders, get your breath back, go, right, that's another one out of the way. When you're ready to push your baby out, that gap where everything relaxes is a lot shorter. And then the next contraction is going to be coming. But it's so important that you make the most of that period when your body is relaxed. So you physically tell yourself, just let your shoulders relax, let your bottom relax, let everything relax. in between contractions is an ideal opportunity for you to have a sip of water. So it's really important that you keep hydrated in labour. And I was going to bring my little wee sticks, and when you're in labour, the midwife usually just keeps an eye on what you're drinking, what your input is and what your output is. So what you're drinking and what you're weeing out, because we don't want you to it's a big job. It's like doing a marathon. So you need to stay well hydrated. So if you're at home before you've gone into labour and your wee is bright yellow, that's a massive signal to say, please, can you drink more water? Water is usually the best thing to drink, not things like fizzy pop, certainly not Coca-Cola, it's full of caffeine. So not pops, not pop, not very sugary drinks. Water's really good for rehydrating you. So you get those contractions becoming a lot more regular, but make the most of the breaks in between. And the good news is, the brilliant news is that even at their most intense, when you're about to push your baby out, contractions don't usually last much more than 1 minute. 1 minute, that's all. That's all. 1 minute, 60 seconds. You ladies, I know how strong you are. You can do anything for a minute. You can do anything. So when you start to feel that build up of a contraction, just think, just breathe through. It's only 1 minute. It's only 1 minute. And that's at the height. And women are strong and they can deal with those. And if you're struggling and if you're not coping, speak to the midwife who's looking after you. Speak to them. They're there to support you. They're there to be your cheerleaders, and you need to be your biggest cheerleader. And this is where your partner has got such a vital role in telling you you're doing such a good job, cheerleading, saying, I'm here right next to you. I'm in it with you. Sometimes men in labour or your partner, sometimes partners really struggle to see their partner in pain because they think this does not look fun. How can I make it stop? And the thing is that the discomfort that you feel in labour is just a muscle working really, really hard. And I've had 4 kids. I know that you feel this really, really intense feeling, but it's kind of not scary. So it's not like you've broken your leg, or not. I have broken my hand and it's just intense and it doesn't stop. The intensity of contractions goes away. So you get a contraction, then it goes away. You get a contraction, then it goes away. You get a contraction. And so, partners, just be there for your partner in labour, because they just want to know that you're there with them to support them. And you're having a baby together, and it's a really, really exciting time for you. And sometimes I feel it's really hard when you see someone getting tired, or it's been going on a long time, but you're there to be their strong person, their support, the one that says, let me get you some more water. Do you want to change position? Okay, so contractions. We've talked about contractions. Your water's breaking. Okay, water's breaking. So your membrane's rupturing. There's kind of no real rule about when your waters should break. We don't want your waters to break before 37 weeks. And then you would, if that happened before 37 weeks, we would need to refer you to the doctor to help decide what the most appropriate plan is. But your water's breaking. It's not water's breaking, then contractions, then have a baby. It can happen in any order, and very, very occasionally babies are actually born. I've only seen it once. Babies are born in their bag of membranes, which is just the most amazing thing to witness. So your waters might break. If your waters have broken, sometimes it's a great big gush, like you see on the telly, but it's not always. So it depends how the waters, the bag of membranes has broken. Sometimes it's a bit of a leak. I'm feeling very dry today. I'm glad I've got my new cup. Okay. Water's breaking. So you should always give them a ring. They're not necessarily going to ask you to come in and stay in, but they more than likely would like to see you just to check. And another question they'll ask you is, what time do you think your water's broke? Because most women will go into labour within 24 hours. However, some ladies, the waters break for whatever reason and they don't go into labour on their own. So again, the doctors will come up with a plan, the most appropriate plan for you to minimise the risk of infection. So it's really important to note the time you think your waters have broken and give them a ring on delivery suite. Yeah, and sometimes what happens is ladies start feeling a bit damp and they think their waters have gone. And sometimes it's urine leakage. It's really, really common. It's not anything to feel embarrassed about. If you've got a baby bouncing up and down on your bladder, sometimes urine leakage happens. So we're not going to tell you off. We're not going to tell you off for ringing the unit. We're not going to tell you off for checking and say, no, your waters haven't broken, but we think it's just a bit of urine leakage. It's really, really common. And if I had a baby bouncing up and down on my bladder, I think I'd struggle as well. So if you're not sure and you think, I feel wet, something's dribbling down my legs, then you need to phone up to ask for some advice and get checked. Okay. Other than that, you can just have your waters kind of like pop and there's a great big gush. So we like you to phone the unit and they can just check you. They might ask you as well what colour you thought the water was, just to make sure there's no problems. And we're hoping that baby hasn't had a poo inside. That's what we're asking you that question for. But they're all to make sure that you get the right pathway of care, so you get the appropriate care. And we need to know if we need an obstetrician to help advise us, or we need a paediatrician, a baby doctor, to give us some advice when baby's born. So, contractions, waters breaking, inducing labour. Okay, inducing labour. One of the main things I say about the induction of labour. So induction of labour is where the doctors make a plan to bring on your labour artificially. They will speak to you about the reason for that and discuss with you whether that's appropriate for you and your baby. And some of the reasons that it's appropriate for induction of labour are if baby on the scans is, if they're worried baby's growth is slowing down, or mum's health is at risk, or baby's health is at risk. You know, we're very lucky that we've got the induction process for those women that it's appropriate for. Sometimes a very tiny baby, if they're worried about them, if they're worried about things like preeclampsia for mum, or any of the other conditions that we might be looking at in pregnancy. But the health professionals, the doctors, will be able to talk to you about the reason for that and why they feel it's appropriate. So the main thing about induction of labour is it's long and it can get a little bit boring. It can get a little bit boring. And the reason for that is that you're going into hospital and you're not in labour. So all that big chunk of time that you usually would spend in your home, pottering about, doing a bit of this, doing a bit of that, watching a bit of telly, going for a walk, having a nice bath, that time you're sat in hospital. And usually what women do is just sit watching the clock thinking, when am I going to have my baby? And the doctors like you to be in hospital for induction of labour because they're doing something to you effectively, and they like to look after you and be responsible for making sure you and your baby are okay with everything that's happening to you. Hi, Barbara. Oh, Barbara, now the pressure's on, isn't it? The pressure's on now. Barbara, you'll tell me, won't you, if I'm saying anything wrong? Anyway, so induction of labour, it can be a long drawn out process. And so first of all, you would go up onto the ward, usually for induction. They will normally, when your induction's been booked, they will normally tell you a time to come in the morning. But I always say, give the ward a quick ring in the morning just to check that they have a bed available for you. Very, very occasionally, the ward's full, and what they certainly don't want you doing at the moment is hanging about waiting if there's no bed for you. So they will keep in touch with you. They might say, we'll stay at home for now and we'll ring you later on this morning, because they don't want you to hang around waiting for longer than you need to do, especially at this time. So sometimes if it's been very, very busy on the ward, generally what happens is there will be a few people that are going home, and because of coronavirus, they're trying to space out discharges, so a load of people are not just going out the doors at the same time. So be patient with them. You know, the staff on the ward are doing a brilliant job to keep everyone safe. So the discharges might take a little bit longer, but it's to keep people, mums and babies, safe, so they're not all going out the door at the same time. So very often, if you're waiting for an induction and they've told you they haven't got a bed for you, very often there is a bed available for you that same day. It might be just later in the day. And bearing in mind, when the ladies have left, the ladies that have been discharged that day have left, the rooms have to be thoroughly cleaned. So I keep banging on about this. I don't know how many of these I go through, but everything's washed, everything's cleaned, and we want it to be as safe as it can be for you. So cleaning is a really important part of our job, to make sure it's good to go. We want it to be right for you when you come onto the ward. So generally what happens is the doctors will tell you to go up onto the ward, and they'll usually give you a time. For some reason, doctors tell people to come first thing in the morning, and very often when they arrive onto the ward, it's the very time that the night shift is handing over to the day shift. So you might not see loads of midwives around. They might be still in handover, which means that very often the first person that you get to see on the ward is our lovely ward clerk. We've got a few ward clerks, so you might meet any of them, and so you can go and introduce yourself. If you're booked for induction, we will have your name and we know you're coming. So if you if it's the ward clerk that greets you, she will be able to show you to the room that you've been allocated, and you just make yourself comfortable. You might be sitting in your room for a little while until the midwives that are taking over on the day shift, so they will get allocated which ladies and which families they're going to be looking after for that day. So and then what happens is the midwife that's your named midwife for that day, she may be working on a long day. She may be working from 7:45 in the morning until 8:45 in the evening, or she might be doing a standard shift, which should probably be going around about 3:30, or she might be doing an afternoon shift, sort of 1 o'clock until 8:45. So that's normally when the midwives hand over. So if you're going for induction, you might be just sitting waiting. And the one thing I was going to say, the worst thing about induction is hanging about and waiting. But please be patient with the midwives and the doctors that are looking after you. The way they work primarily is to keep everybody safe. They want to make sure everybody gets safe care. So say I was allocated on the ward to look after you for that day. I might have some other ladies and babies to look after, and a certain baby in another room might be having observations every 3 to 4 hours. And on my little list of jobs to do, I might have baby X needs baby observations at 10 o'clock, for example, or at 9 o'clock. So if I've just come on shift, I need to go and see that mum and baby to make sure that baby gets the observations at the right time. So I haven't forgotten about you if you're coming in and you've had induction. It's just that I know that the ward clerk's spoken to you and you're all right in that room. But by all means, if there's an emergency or you do have a call bell in your room, and it's an orange button, it's on the handheld thing on the wire, and the maternity support workers can tell you things, you know, your buzzer and things like that, because of all the restrictions, they don't really want people wandering about in the ward. So normally people would just wander up and down and ask a midwife. So you might find that you need to press your buzzer if you need some help. Obviously, if it's an emergency, you know, you would buzz for a midwife to come. Otherwise, the midwife who's named to look after you will come and see you. What I try to do when I'm working on the ward is I try and quickly nip round all the rooms just to introduce myself to the ladies, to make sure they know who their named midwife is. So it's fine for you, once you've met your midwife on the ward, and she'll tell you a name, you know, and it's fine for you to ask her. She won't mind you asking you. Or we do have some male midwives. We have the beautiful, gorgeous Andy, who's one of the loveliest people you could meet. Let you know their name, and it's fine to ask them how long they're going to be staying for. Very, very, very occasionally, what happens is, in the middle of the day, we get a little bit of a jiggle round. So sometimes what can happen is I can come and I can say, I'm allocated to look after you all day. I'll be here for you all day, and I'll be here till 9:15. That's happened. That's happened before. And because of the workload on delivery suite, I've been asked to go and help give them a hand on delivery suite, and if it's been something that's been quite urgent, I might have just had to go. So then you might find yourself with a different named midwife. Anyway, I'm just going to see what this says. Amanda, what is the situation with partners being at the birth? Are they only allowed in at a certain time? So you need to check with your own midwife current guidance and restrictions, because we know that they're changing, Amanda, all the time. At the moment, as far as I know, on the ward, partners are not allowed on the ward unless it's to be with a mum who's been induced. So partners are not allowed to come up to the ward after you've had your baby. However, if your baby is in transitional care, so being looked after by the neonatal nurses, and a baby that needs extra monitoring or observations, and they will tell you if that's the case, partners are allowed in for an hour in the evening. Don't quote me on this, but I think it's 8 till 9. I think it's 8 till 9. Check with them on the ward, but I think if your baby's on transitional care, partners can join you on the ward for just an hour in the evening. However, on delivery suite, you're allowed one birth partner, so not the normal 2, just the 1, and your partner can stay with you on delivery suite. So you can have your partner at your birth, and we want them there to support you because you need your partner. So just double check that those things haven't changed, but that at the moment. And also mums and partners are offered a COVID test swab as well. And for anything, any appointment that you're attending in the hospital, obviously you shouldn't attend if you've got symptoms of coronavirus. You should contact your own midwife. And I've had a few ladies from clinics who've had to postpone clinic appointments because they've been asked to self-isolate. So your midwife will be able to chat with you over the phone to check that you're okay, to check that there's not anything, any concerning things like, obviously you should never ignore it if you're worried about your baby's movements. You must always get that checked out. And, you know, thank goodness, everything's working quite smoothly in delivery suite. And, you know, I am proud of our team. I am proud of our team. Everyone's working so well together. Our managers are being really, really supportive. And we just want you to feel looked after and supported as well. So, inducing labour. I know I'm going on a bit. What time are we on now? 1:30? Not even got halfway down my list. Right, we'll crack on, because this is an important one, I feel. And the reason why I'm doing it on here is so I can spend the time with you to go through everything. And, you know, by all means, like Amanda's just done, drop me a question. And I'm coming on to some other things. So induction of labour. So you go up onto the ward and you get shown to your room. Midwife comes and introduces herself to them. You will, normally, the midwife will ask you to provide a urine sample, and they will just check it. You know, the little sticks. I did have my little sticks, but I don't know what I've done with them. And you might be familiar with these things. These elastic straps. So they go round mummy's middle, and if you're being induced, the doctors would much prefer you to have these on for the continuous monitoring. So it goes round your tummy like that, and one of them holds it's like a disc about that big, and the top one monitors your uterine action, and the one that's usually low down, if your baby is head down, is the one that monitors the fetal heart, or the baby's heart. So if you're being induced, we like you to have continuous monitoring, because we want to make sure that whatever we're doing to mummy, baby's okay with it, because we have to acknowledge that we need to look after this baby in labour as well. So we need to look after the baby, and we can just make sure baby's okay with whatever's happening to mum. So before your induction starts, they like you to have the monitoring on the CTG machine, usually for about half an hour if it's normal. And the midwife will be able to interpret it. If there's anything that is concerning her, she might get a doctor to come and have a look just to make sure everything's okay. And then they will offer you the pessary that's inserted into the vagina. It goes, they just tuck it just behind the cervix. So sometimes it can be a little bit fiddly, and sometimes it can be, you know, you might need to get yourself into a wiggle down position so the midwife can actually reach to put it in the right position. So we used to have a prostin pessary, which looks like a big paracetamol. That's what it looks like. And so that is inserted, and then you stay on the monitor for about half an hour after that's inserted, just to make sure it doesn't just fall back out, and make sure baby's okay with it. And you would be with the they don't use them as much now, but the prostin pessaries, they would review you or offer you a vaginal examination after 6 hours. So what they're choosing to use now, usually, but the doctor will decide which one's more appropriate for you, is it's like a little Propest gel thing it is, and it's only that big. Oh, Amanda, I hope so as well. Okay, so it's like a little gel thing. It sort of expands a little bit inside, and it's on a string, a little bit like a tampon. So that's inserted in the same way, but in my opinion, that's they're a really good thing if they're appropriate for you. So if the doctor's prescribed that for you, because you don't have to have so many vaginal examinations, so that can be left in for 24 hours. So you can see that we put that in and then leave you for 24 hours. Obviously you do have a named midwife, but that's where the boringness can be. So what you need to do is make sure you've got films downloaded on your phone, or a good book. It's a good book, because what we don't want to happen is you go in to be induced and all you're doing is watching the clock, getting yourself anxious, going, when am I going down to delivery suite? When am I going down? You go to delivery suite when it's safe and appropriate for you to do so. So it can take a little while. So just be patient and think, right, well, I might be here for the next day or two. Few days. Hello, darling. My doggy come to see me. That's he's brought me a sock. I don't want a sock, thank you. I'm busy. Right, okay, so inducing labour. Then, so these are this is the gel that we use. So we use that it's a lubricant gel. We use that when we're doing a vaginal examination, and we also use sterile gloves. So we don't use the normal ones out of the boxes on the walls. We use sterile gloves. Also, it's always, if for example any kind of vaginal examination, we will have a listen to baby. If for example in the community we do sweeps when you're past your due date, and we will always have a listening first and after we've done a vaginal examination. So they're the things that we use. Right, where am I up to? Inducing labour. So once you've had your little pessary on the ward, what they're hoping to do is hoping to soften and open the cervix enough to be able to break your waters. So the next step in the induction process is artificially rupturing your membranes or artificially breaking your waters. So that's not usually done on the ward. That's normally done on delivery suite. So once you've been assessed and the midwife thinks or doctor thinks that you're ready for appropriate for us to be able to break your waters, you will kind of go in a queue. So once you're ready to have your waters broken, you don't always immediately go down to delivery suite. If you're up on the ward and you've had a monitoring and you and baby are okay, you're safe and you're okay on the ward, what we don't want to do is send you down to delivery suite when it's busy on delivery suite and there's not a midwife to look after you or a room. So you then go down to delivery suite when there's a room free for you and a midwife to look after you, because on delivery suite you will get one midwife looking after you for one-to-one care, hopefully. So we should be able to offer you a one-to-one midwife. It's usually one midwife looking after you, especially in labour. So once there's a midwife free to look after you on delivery suite, she normally comes up to the ward and collects you and she can introduce you there. So it's not necessarily the midwife looking after you on the ward that will be looking after you on delivery suite. So you might get a different midwife looking after you on delivery suite. So she'll show you to your room, and you can make, it's usually bigger down on delivery suite. You can make yourself comfortable. The midwife or support worker will be able to show you where your nearest toilet is, and you know, show you where the buzzer is and what have you. So when you're comfortable on delivery suite, the next process is breaking your waters, and the midwives use what we call an amni hook, and that's what it looks like. So it's rounded on the edge and it's just got like a little, it's almost like a little crochet hook, isn't it? So sometimes that's, the midwife slides it up her finger, or if the doctor's doing it, and just gently nicks the bag of waters. So it shouldn't hurt baby, it shouldn't hurt mum. Sometimes it's a little bit fiddly, but it shouldn't hurt, and it doesn't poke, you know, it doesn't scratch the baby's head or anything like that. So that's that. And then the next process, so once your waters have been broken, the midwife will look and just check that the colour of the water is what we're expecting to see. So you will, don't forget, you'll have your so you'll have these straps on, and you'll have the monitoring. So the monitor is CTG machine next to the bed usually. It's on wheels, so you don't have to be stuck to the bed. You're attached to the machine, but the machines are on wheels, so you can, you know, you can, we as midwives, it's our job to try and facilitate you being able to move, or, you know, be in a position that you're comfortable with. So if there's something that you're not happy with, or you're really not comfortable, just mention it to the midwife, and we'll try and see if we can rearrange something to make you more comfortable. So we talked about methods used. So after your waters have been broken, then what you need, they don't usually put it in your hand. They normally put it somewhere on your arm, usually round about there. A cannula. So a cannula, the midwife or doctor will be able to put a cannula in. So the cannula, they use a needle to introduce it, but a cannula, they don't leave a needle in your arm. All it is it's a really, really fine plastic tube that's used to give you fluids straight into your blood vessels. So that's what that's for. So the midwife will be able to do that for you. Sometimes it gets a little bit uncomfortable, and sometimes it's a bit just fiddly. But if you've got any issues with that, have a chat to the midwife. So the next job in the induction process is to get a bag of artificial hormone. So the artificial hormone is what will encourage your uterus to contract. And what they're trying to achieve is 4 intense contractions in 10 minutes. So the drip is controlled by the midwife. The midwife usually will turn it up every half an hour. When you're on the monitor, it'll give us a good idea of how baby's coping with that. So we come and have a check on that to make sure baby's okay. Sometimes we have to turn the drip down, and sometimes we have to turn it off. So we will be closely monitoring how baby's doing if you're being induced, and how mum's doing. I always tell my mums who have got a planned induction to really have a think about analgesia or pain relief before you have your induction, because it's really good to know what tools that you've got to help you cope in labour. It's getting really dark. I hope you can see me all right. So that's induction. The reason. Assessment during labour. So the midwife who looks after you in labour has quite a lot of documentation to do. There's lots of things that we need to record in labour. So we record baby's heart rate every 15 minutes in the first stage of labour, and every 5 minutes at least in the second stage of labour. And by the way, the first stage of labour is your labour, so getting your contractions up until the cervix is 10 centimetres or fully dilated. So when the cervix is 10 centimetres or fully dilated, that's how big it needs to be to allow baby's head to come out. So we need to get you to 10 centimetres. So it's 10 centimetres, and then the baby's head will start coming through. Once you're 10 centimetres or fully dilated, you enter the second stage of labour. So what naturally happens is, once the cervix is 10 centimetres or fully dilated, the baby's head naturally will start to get pushed through. The midwives are there to support you physically and emotionally through labour, and also just to keep your spirits up, really. So what would happen if you didn't have a midwife there at all? And we do want you need to have a midwife there. Is baby's head would get pushed down, and then mum gets an automatic response. that she starts to bear down and push down. And it's because when baby's head starts to come through, that's what causes this involuntary response to push down. So when you hear midwives say, you'll know when to push, your body knows when to push, it's that automatic feeling of wanting to push down, and it feels really, really natural. So don't worry about when will I know, when will I not know. You know, if you don't know, your midwife will tell you. There's only very, very rare situations when mums get the sensation to push before they're fully dilated, and it's usually if baby's in an unusual position. But they'll be able to tell you about that. So fetal heart every 15 minutes in the first stage of labour. Once you're fully dilated and baby's coming through the cervix, that's the second stage of labour up until your baby's born. And the third stage of labour is the bit that the placenta comes out. So the placenta coming out is the third stage of labour completed. So in the first stage of labour, the midwife usually will check your blood pressure every 4 hours. And she'll check your pulse every hour, or sometimes they do it more often than that. They will check your blood pressure more often than 4 hourly if it's out of our normal limits, just to make sure. And the midwives need to check your blood pressure much more frequently, every half an hour, if you have an epidural, because the epidural can sometimes lower your blood pressure. So they like to keep a much closer eye on your blood pressure if you have an epidural or a spinal. And I'll tell you what they are in a minute. We're coming to that bit. So other observations also are on our sheet that the midwives fill in labour. They've got a fluid input and output, so the midwife will note down when you've had like a 750 ml jug of water, and every time she's filled it up, she'll document that she's done that. And also they will want to measure your urine output. So, and the reason they do that is because it's hard work being in labour, and they don't want you to get too dehydrated, because if you get really dehydrated, it can just make your heart rate go up a little bit, and the babies, and we don't want that. So it's really easy. It's really easy to keep you hydrated. For some ladies in labour, if they've been vomiting a lot for whatever reason, sometimes the woman might need a cannula in to give them some fluid straight into the blood vessels, but not everybody needs that. So when you have a wee in labour, the midwives usually want to measure the volume that you've weed. So she'll usually give you a paper mache little thing. It looks like a hat. A paper mache thing that just goes into the toilet. So if you wee into that, and then you can give her that. Midwives are used to dealing with wee. Don't worry, we're used to dealing with it. So she'll be able to check that you've been drinking enough water, and if it's proper yellow, she'll be asking you to drink a little bit more water. So that's a really good way we can tell that you're not getting too dehydrated. So she'll document all that as well. So we've said fetal heart rate. She will also document things like if and when your waters have gone, what colour it was, if you've had any analgesia, if you've needed any painkillers, you know. And very often we write about how are you doing as well, you know. And so let the midwife know if you're all right, you're comfortable, or if there's anything we can do to make you more comfortable. It's your labour, it's your special day, it's your baby. We're here to look after you, and we want it to be a really special day. We want it to be as nice and as special as it should be. And if things happen that we weren't expecting, or you weren't expecting, we're there. Hopefully we can explain things and reassure you and be there every step of the way and look after you. Because we get, midwives get so much satisfaction out of doing a good job. So we want you to let us know if there's anything you need from us. And that's where these people come in. Someone at my door. Chloe, please will you go to the door? Oh, is it my son coming in from school? Okay, so we're talking about assessment during labour. So we do a lot of writing. So they're the things that we're documenting, because we need to make sure that we've documented everything that we need to. Right, posture during labour and during delivery. Generally, as a rule, women will take up whatever posture in labour and to have their baby is comfortable for them. So everybody's different, and some ladies will prefer to give birth on their hands and knees. Some ladies prefer to give birth standing up. Some ladies prefer to be in the pool. Some ladies prefer to be sort of semi-recumbent, just laying back. You know, some people want to have their feet supported by something, you know. So let us know how you feel comfortable. And if midwives are really good at being able to interpret whether you don't really quite know what you want to do with yourself, because sometimes you can feel a little bit like that, you don't really know what you want. So the midwife often will suggest different positions that might help. And sometimes if there's any concern about baby's heart rate, sometimes the midwives or doctors ask you to lie on your left side. But as a rule, just you let us know how you're comfortable. And there are some positions that are a bit more active than others in labour. So during delivery, okay, eating and drinking. Labour is like doing a long marathon. You definitely need to keep well hydrated. And if you're coming up to your due date, have a look at the colour of your wee. We should all look at the colour of our wee. So when you've had a wee in the morning, have a look what colour it is. If it's dark yellow, dark brown, you need to drink more water. You know, it's amazing when the little samples of urine that I check in clinic, you can tell the ones that are doing really well, because it's so pale, it's clear and pale, and you're doing such an amazing job of drinking plenty of water. And then, you know, so if you have a wee in the morning and it's dark, bright yellow, just try and drink a little bit more water. And if you're coming up to your when you're expecting to go into labour, you know, if you're already dehydrated before you start, it's so much harder to catch up. So always have water to sip. And snacks. Very often in labour, women don't want to eat a huge meal. So it's very often just little and often's good. So things that are going to give you energy, you know, things that are going to provide you with just something quick and easy to eat, healthy, and it's going to give you some energy. So, you know, try and make an effort towards the end of pregnancy to eat a little bit more healthily. Try and choose some healthier options. Okay, pain relief. Okay, natural methods of pain relief. The first perfect natural method is relaxing. What we want you to do is produce happy, calm hormones, not fight or flight, adrenaline, stress hormones, because we know that labour is stimulated by oxytocin, which is the love hormone. We want you to produce lots of your own oxytocin. So if you're around the time of your due date and you want to have your baby a bit quicker, Google how to increase your oxytocin naturally. And there's lots of things you can do. Having contact with a loved one, you know, spending time with family and friends is more difficult at the moment, but maybe just having a conversation over the phone and, you know, catching up with somebody you love that you've not spoken to. Having a walk in nature is so good for your mental health. That's always you know, especially if in winter we get a little bit of nice weather or sunshine, that's really good to help your healthy, happy, calm hormones. So natural methods, we've got relaxation, things like hypnobirthing. And KG, you'll see where's my badge? KG Hypnobirthing. So I'm a hypnobirthing teacher, but I don't do classes because I just can't seem to find the time. Aromatherapy, massage is amazing. If you can get your partner to give you some practice massaging sessions. Very often ladies in labour really like having their lower back somewhere just sort of around the coccyx area. Sometimes when you get a contraction, it's really, really helpful to have somebody to massage that bit for you. So, you know, in labour, midwives are really good at showing partners how to just do that really low back massage that's so helpful. Water, there's just the one pool room at Lancaster. But if you'd like to use the pool room, have a word with your midwife, have a chat with her to make sure that's the most appropriate place to have your baby. If you've decided that you are going to use the pool and it's fine with the doctors are happy for that to happen, if you just let them know when you ring up delivery suite that you want to go in, if you want to use the pool room, because obviously if somebody's using the pool then it's not available, but we will always try and get you into the pool as soon as somebody's finished using it, if that's what you wanted to do. Aromatherapy, I have actually done an aromatherapy course, but it was a little while ago. There are lots of so I'm trained in a few of these specific oils: clary sage, frankincense, lavender, mandarin, peppermint, spearmint. So I know about these ones, although I would have to consult this manual that they gave me to make sure that I was giving the correct advice, because there are certain things that certain oils that you have to be careful with. So if any of my ladies is interested in aromatherapy, that you can always ask me any little tips or things, and it's got things like massaging in there. Ooh, massaging, how to do that, and what you can use the oils for, and it tells you the dilutions, so you've got to be careful about how much you dilute in bases and other oils and things. And one of the big precautions is clary sage. So clary sage, it's indicating during labour or after 40 weeks, because it's supposed to encourage uterine action, so it's contraindicated during pregnancy. So that's not one that you should use in pregnancy. It should be used in labour or after 40 weeks. And here it'll tell you what, so we've got lavender is good for relaxing, calming, cooling or fear. And then we've got things like clary sage, increasing contractions, reducing tension and pain, going into the dream space. How lovely is that? Peppermint's really good to ease nausea. Lavender and peppermint, cooling, refreshing, ease headache, fear. Frankincense, reason for use, asthma, fear, letting go of fear from the past. How interesting is that? So there's different things that you can mix with, but that's I think all too often we forget about our senses. We forget about our senses, don't we, when we're looking after ourselves? But our senses are really important. So next thing on my list is Entonox, often called gas and air. So you'll be probably seeing them, the great big cylinder things. They used to give that to kids in dentists for pain relief. So it's a big canister. The midwife will turn it on and off for you, but you get your own personal mouthpiece. This is just one I use to show people. So it's plastic, and that bit goes in your mouth. So I always thought that these mouthpieces are really good to give you something to really focus your breathing on. But what I will tell you as well is when you breathe in Entonox, in and out of that, all too often it makes a funny squeaking noise. So they do make funny squeaking noises. So when you inhale, so you're supposed to make sure you fill your lungs with it and get a good, start breathing it in the moment, you know, when you feel your contraction coming on, and you don't need it if you haven't got a contraction. So just breathe all the way through. That Entonox is what got me through 4 labours. Really gives you something to focus on, because very often you shut your eyes and you become really, really internally focused. It's an amazing state of being when you're in labour, because you're so internally focused, and that's normal and that's natural. But don't let the squeakiness of the Entonox freak you out, because it is squeaky. You breathe in and it goes, you know. If the midwife can readjust it or something, we always will try and do that for you. So that's the Entonox. Injections. So injections are kind of opiate. In Lancaster they're using diamorphine, I think, at the moment. So it's an injection, usually goes into the top of your bottom, that the midwife will give you, and it's quite good for early labour if somebody's finding it particularly hard. The diamorphine works well as a painkiller, although it can make mums and babies a little bit sleepy. So it can make you feel quite sleepy, which is good. We try and avoid giving you that opiate injection if we think your baby is just about to be born, because it can diamorphine is amazing. It's a really, really, if it's used appropriate, it's really good. But your midwife will talk to you about what's the most effective and appropriate painkiller for you. So what we don't want to do is give you a massive dose of diamorphine and your baby's born, because they come out and they're a bit sleepy as well, and we don't want them to come out like that. We want them to come out and take a big breath and do us a big cry if they can for us. So and also what we don't want to do is we don't want to give you a massive dose of diamorphine and put you in the pool, because that's not appropriate. We don't want to do that. So they wouldn't want you to get straight in the pool if you've just had a dose of diamorphine. So epidural and spinal. So epidural is the thing that's administered by the anaesthetist. So if you want to have an epidural, sometimes you have to be patient with us, because what we have to do is midwives then have to request, we have to call the anaesthetist, bleep the anaesthetist, they call back, and then we tell them that we've got a lady that would like to have an epidural. So they might say to us, I'm really sorry, I'm across in the other theatre at the moment, I'm going to come, I'll be with you as soon as I can in, you know, however long. So sometimes they will be looking after other people and we might have to wait for them. Most women get an epidural that they want, but we can only get them to come when they can come. They're really good, the anaesthetists. They will come when we ask them to come, and they're usually there straight away, pretty much. So what they do is they have to get you to sit on the bed in a certain position. So they will adjust you, and bearing in mind you might be in the throes of labour, so sometimes it can be a little bit tricky, and you have to work with the anaesthetist and let the anaesthetist know when you're getting a contraction, to make sure they can do what they're doing safely when you're at your stillest. So they'll get you to sit on the bed, and they usually get you to arch your back, and they say like a cat arching the back. So they need you to open the spaces in your spine so they can get the epidural in the right spot. So they have to have a gown on, they have to have a sterile field. They very often will have a midwife there to open packets and put them onto their sterile field for them. So the anaesthetist will introduce the epidural in your back with a needle. So they'll use a needle to put the anaesthetic in, the local anaesthetic, but they won't leave any needles in your back. It's not a needle in your back. All they do is they put a tiny little epidural catheter, which is just, as far as I can see, like a tiny little plastic tube. That just stays in there, and they tape it up your back and it comes over your shoulder and it's attached to a pump, and then you get a handheld device with a button on the top that you control when you need a boost of it. So that first of all, the anaesthetist will set you up, and hopefully you'll be nice and comfortable, and then you've got the boost button. So the boost button has got a like a dose control and a time out control, so it's made so you can't overdose yourself with it. So if you're pressing it 15 million times and it's not doing anything, sometimes we need to get the anaesthetist to come back and see if there's anything they can do to make it more effective. And a spinal, so with an epidural, you normally find that you're numbed a little from there downwards. They use a cold spray to check where you can feel from. So they'll say, can you feel that cold? Can you feel it? So they use that to check how far up the block is. And normally you can still sort of move your legs, wiggle your toes, but they feel quite heavy. So it's good to help with relief of contraction pain when you're in labour, if that's what you want. You don't have to have an epidural, but if you have an epidural, it just means that they will check your blood pressure much more often, and we do like you to have the continuous monitoring on as well. Where are we up to now? So epidural, and a spinal is the thing that they would use if you needed to go into theatre for anything. So a spinal is what you would have for an operation, so a cesarean section, so you absolutely can't feel anything from there down. So that's what the anaesthetist would use if you needed to go into theatre for anything. Okay, so they're your pain relief. And vaginal birth, you know what that is. Water birth, you know what that is. Cesarean section, obviously, they will do a little cut, sort of bikini line it is, and they're so good. Oh, we have some good doctors. We do have some good doctors. They do a really neat cut, even for emergency sections, and they, you know, in the olden days, used to be up and down, but they do a really neat cut, so when it's healed, you can barely even see it. And then they do like a running stitch usually with dissolvable sutures. Occasionally they put individual stitches in that the midwife in community will take out a few days afterwards, but usually they're dissolvable stitches. Cesarean section, and if you do need to have a cesarean section, usually that you would stay in hospital a tiny bit longer than if you didn't. Right, assisted vaginal birth or an instrumental delivery. Does anybody know what that is? Do I need a light on? Is that better? I've got a light on now. Okay, so instrumental delivery is something that or it's sometimes called an assisted vaginal birth, is if in the second stage of labour, so when mum's fully dilated, so you can't have an instrumental delivery if you're not fully dilated 10 centimetres, and babies not being born as soon as we would like. So sometimes an instrumental delivery is indicated if baby's getting a bit fed up, because when baby's head's ready to be born, it's getting a bit squeezed. There, and sometimes babies just get a little bit tired with it and a bit fed up of being squeezed. So sometimes the doctors decide that baby's had enough and baby needs a little bit of help. So unfortunately you need to put your legs need to be put up in the stirrupy things up at the side so the doctor can come and do the instrumental delivery. So it's not the most flattering of positions, I can tell you, but they put your legs like that because that's the position they need you in. And the first instruments they use are one of them's like a suction or ventouse. So they put a little, it's often they use a kiwi ventouse. So it's a little sucker thing that goes on baby's head. And as mum pushes, doctors gently pull just to help baby out. And the forceps look a little bit like metal salad spoons. So they go, the doctor puts them round baby's head like so, and when mum pushes, doctors gently pull to help baby be born. So one of the things with a instrumental delivery is the doctors will normally like to do an episiotomy. Right, so what I'm going to show you, I'm going to remind you about the perineum. My printer's gone rubbish, but you can stop that and have a look at it. But you can see, so we've got the urethra there. So basically that urethra, that's where you wee out of. So women have 3 holes, and that's the vagina. So that's where baby's going to come out of. And then you've got your anus. So can you see here, this bit here, they're the transverse perineal muscles. So you can see that the perineal muscle is between the vagina and the anus. So, you know, so that's the muscle that we're always going on about that needs strengthening after you've had your baby, pelvic floor exercises. Do you remember this? Don't forget pelvic floor, squeeze, pull up, hold. So make sure you've got your bag of shopping nice and strong. Okay, so episiotomy, if that makes sense. So that's fetal head bulging, so vaginal opening, you can see. So that there is normally, the doctors will use some anaesthetic. They do use some local anaesthetic, so don't panic if that's needed. So they often need to give you a little cut there so they can get the instruments in. The doctors are brilliant at doing the stitching up afterwards. So the doctors, after they have done an instrumental delivery, it's the doctor that will sit there and take time to make sure that that's stitched up nice and snug. So you can have your Entonox, but they do use local anaesthetic when they're doing the stitching. Okay, so we've talked about that. Breech is on my list. So breech is if at 36 weeks your baby is bottom first rather than head first. So we would rather babies are head first, ready for birth. And if your midwife finds that baby's breech or bottom first at 36 weeks, so before 36 weeks we don't panic too much because babies have got a little while to turn round. So we would like baby to be head down, ideally. But if baby at 36 weeks is bottom down, we would refer you for a presentation scan. And then if baby's head down, everyone's happy. Sometimes midwives get it wrong and feel like a bottom's a head and a head's a bottom, because we can only see, guess by where we're listening to the heart rate and what we're feeling. So if you go for a scan and baby is bottom down or breech, then the doctors would start getting involved in your care and talk to you about what we call ECV, so trying to turn baby round. But the doctors would take over from there and talk to you about what your options are. What about if babies are back to back? Now I'm glad you mentioned that, Leah, because I was nearly going to forget that. Right, so if baby's back to back, don't panic if baby's back to back. It's just that if baby's back to back, or sometimes you hear people calling it OP, occiput. That's the occiput on the baby's head, posterior. So what it means is that instead of, right, your back's going that way, the best position for baby is if baby's back's curled round that way, like that. So baby's sort of facing you, if you will. If you imagine baby inside, so if baby's sort of looking that way, so if baby's looking that way towards your back, that's the best position of baby for baby. And it just means, it normally means that babies that are in a good position or OA position, they tend to tuck their heads in a bit better, and this nice round part of the head gives nice even pressure on the cervix, so it tends to just help the labour along a bit more efficiently. If babies are back to back, so if you imagine baby is looking out to the front, or if you imagine if your baby was born like that, baby would be gazing at the stars or looking up at the sun. All it means is that babies tend to have the head a bit more like that. So instead of nice and tucked in with this part pressing on the cervix, they tend to have the head a bit more back like that, a bit further up like that. And then this part of the head, which is more that shaped rather than round, it doesn't put nice even pressure on the cervix. So that's sometimes why labours can take a little bit longer. And just a mechanical thing, women tend to get a little bit more backache because baby doesn't fit in quite as snugly. But there is good news. There are lots of positions. Ask your midwife about positions that you can do to help baby into a anterior position, and they're usually positions where you're leaning forward. So leaning forward, okay? So if you are always sat at home on your couch like that, yeah, it's not going to do anything for a posterior baby. If you're always laid like that on your sofa, the baby will probably just stay in an OP position. But if you do positions, and you could, like if I've got this, oh hang on, I'm getting tangled up in my wires. I didn't expect to do these demonstrations, but if you sit on a chair like that or on a birthing ball and just lean forward, that can help baby into a better position. But they're all things that you can Google. I'll have a look, see if I can find any resources, best position for your baby. But your midwife will know. Ask your midwife about positions. So we've talked about perineum, we've talked about episiotomy. For first time mums, getting a natural tear to the perineum is really, really common. Please don't panic about that. Please don't panic. It's normal and it's natural. You know, some ladies have a little bit of a tear, and sometimes it can be if babies sort of been born with a hand in a funny position or something like that. Sometimes that means that you might get a little bit of a tear. The midwife who looks after you in labour will just check you over. I know it's horrible having people looking at your bits. I know it's horrible, but us as midwives, we are so used to examining women in that intimate area. It's a big part of our job, and we want to look after you, and we want to make sure that if there is any damage to the perineum, it's tightened up and everything's repaired properly so it can heal well. So the midwife, when you've just had a baby, the last thing you want to happen is people poking about at your bits. That's the last thing you want. But it's really important that we have a check, and sometimes it can be a bit uncomfortable to have the midwife checking. You can have the entonox while she's checking, but she's checking you down there because she cares about you, and she just wants to make sure that, I mean, midwives are good at sewing. Midwives are really good at sewing, and we just, when I'm doing any suturing of a lady when she's just had a baby, I'm thinking, do you know what? If somebody was sewing my bits, I would want them to take extreme care over what they're doing. So the midwife really just wants to do most midwives, you know, their main focus when they're doing the stitching is how brilliant a job can I make of this. It's really important after you've had a baby to do your pelvic floor exercises. Don't forget pelvic floor. And put your post-it notes round. It's that squeezing of that muscle to try and get the strength back in it. What else did I want to talk about? Oh, I tell you what, the observations in labour. So not everybody will need a continuous monitoring. Not everybody will need continuous monitoring. Sometimes we can use a sonic aid if we're looking after a lady who is midwife-led care or low risk. We can use a sonic aid. We put some gel on the end of there and it makes a funny noise and we can listen in. So we like to listen in, and we will listen in using one of these if we attend a home birth. These sonic aids, midwives don't like you using them at home, because I've mentioned this before, because we're trained to use these, so we know what sounds normal and what is something that might concern us. So if you're not trained to use them, you shouldn't be using them. If you've got concerns over your baby's movements or anything else to do with your pregnancy, you need to be speaking to a qualified professional to ask their advice, and then we can make sure that we give you the best and the safest care. The other thing that I didn't mention, we talked about bladder care when you're in labour. So the midwife will encourage you to go to the toilet quite regularly when you're in labour, because number one, you should be drinking plenty of water and your bladder will be filling up. Because your bladder is in quite a close space where your baby's gonna be coming down, if we just leave your bladder to fill up and fill up and fill up and you don't have a wee because you're too focused on these contractions, you know, it can stop baby from coming down as efficiently. So most women are quite able to get up and go and sit on the toilet in labour and have a wee. However, if you have an epidural, one of the downsides of having an epidural is you can't feel when your bladder's filling up. So the midwives want to make sure that your bladder is emptied. Make sure your bladder's empty. And I'm going to open this to show you properly because you can't really see it in the packet. So obviously the midwife will be using sterile gloves, not like me. I'm just keeping this one to show you. And she doesn't, this is an old one that it's no good anyway. It's all stuck to the packet. So this is called an intermittent catheter, and where's my thing? So you can see the hole there that you wee out of. So it's a little hole there. So because if you've got an epidural, you can't empty your bladder because you can't feel that you need to go. Sometimes the midwives want to introduce an intermittent catheter, which is a tiny little bendy tube. So she will have washed her hands. She will have sterile gloves on, and just insert that into the hole that you wee out of, the urethra, just to empty your bladder, and urine just comes out of that tube there and into a pot, and then we can measure it. So that's to look after your bladder. We're not doing it to you because we want to be horrible. And if you've got an epidural, you know, it's not going to hurt. You won't be able to feel it if you've got an epidural. Right, okay, so 2:30, right. Been going on for ages, haven't I? Right, delivery of placenta. So delivery of the placenta is the third stage of labour. So When you have your baby, your midwife might ask you, you're happy to have immediate skin to skin with your baby. So baby's born and midwife puts baby on your chest. Usually we just try and dry baby off with a normal towel, and that will hopefully stimulate baby to do a big breath and start breathing for themselves on their own. Some babies might need a little bit of help immediately to start breathing. If that's the case, there is a resuscitator, which is like a trolley thing that we put baby on, and it's got its oxygen supply and what have you if baby needs any extra help. So the midwives are trained to use those, and most babies, by the time you get them to the resuscitator, they've already started crying and it's all fine. But the midwife would tell you if there was anything that they were concerned about. Baby's delivered onto your chest, skin to skin, and then your baby's still attached by the cord, and it's still attached. It still goes inside mummy where it's attached to the placenta. So the placenta is quite a big vascular thing that your baby has been getting all its nutrients from, and the placenta needs to come away. So if we don't do anything, the uterus will contract down and the placenta comes away. But what they will give you an option for is active third stage of labour, which is an injection into your leg, and what it does is it tends to contract the uterus a bit quicker, and the doctors might recommend that if they want to minimise the chance of bleeding. So lots of women choose to have that, but it's called physiological third stage if you don't want to have the injection. But you can discuss that with your own midwife, because it's you do have a choice. The cord has the blood vessels in it, and that's the baby's blood in the blood vessels. So years and years ago, they used to cut and clamp the cord straight away. Excuse me. So now it's good practice to leave the cord for as long as we can, usually until it's stopped pulsating, to make sure the baby's got their own blood out of the cord. So we very often will feel it to make sure it's stopped pulsating before we cut and clamp it. Dads or partners have the option to cut baby's cord. If it's an emergency or baby needs it cutting quickly, the health professional will usually do it. But if you discuss with your midwife, you can let them know. Some dads say, yes, I really want to cut baby's cord, and some dads say, no, I really don't want to cut the cord. It's like cutting through gristly meat. So it doesn't hurt baby when you cut it. And then they'll put the little clamp on it for you. Other things to consider. So consider options how you're going to feed your baby. If you choose into formula feed, you need to take your formula into the hospital with you. If you are choosing to breastfeed, there's midwives there that can help you if it's your first time, or if it's not your first time, you're still allowed some help, because each baby's different. So even if it's not your first baby, it's okay to ask for help with breastfeeding, with anything for that matter. And if you're undecided, that's fine as well. We can just see how you go. You can just see how you go. Excuse me. So you can just see. Is that my daughter sending me a message? So, you put me off my stride now, Charlie. She's waiting for me to do something. So, there's help there, whatever you choose, and it's all right to be undecided. We can sort of help point you in the right direction anyway. Okay, delayed cord clamping, we've talked about that. And the other thing that your midwife will ask you about is vitamin K injection for your baby. So have a little read up about vitamin K, ask your midwife, but we do have to ask for your consent to give vitamin K to your baby. It's an injection in your baby's leg. However, you could opt for oral drops, but you have to give subsequent doses as well. And it's you know, think carefully about whether you want it or not, and ask the midwife if there's anything else you want to know about it. So on this here, we've gone through that list, but what I've put on there is, and I know this is the wrong way around, safe sleep for babies, and I've put on the link for the Lullaby Trust. Safe sleep for babies is really important, so there's some really important information on that website for you. And the other thing that I came across was this old leaflet, Baby Maze. So your local online guide. So the Baby Maze is a useful guide for parents-to-be and families with young children in Lancaster, Morecambe and the South Lakes. The Baby Maze is really helpful information. It'll give you information about health visitors and how they're working at the moment, because a lot of the health visitor clinics have been changed because of all this lot. And on there as well, it tells you our normal pattern of visits. So normally a community midwife will come and visit you the day after you go home from hospital. Then they'll come and see you on day 5. So on day 5, considering that day 0 is the day your baby's born, and they will do the newborn blood spot test, which is on a piece of blotting paper that looks something like that. And they will use this little clicker thing. So they take that off. That goes on your baby's heel, and they press that in, and it just nicks these are made for, it's called tenderfoot for the newborn. So these are made for newborn babies, and it just nicks the surface of the skin. And then we just let the drips, we need 4 drips of blood on there. But they're really, really specific about how it has to be done and how it shouldn't be done. So a really good tip when you're expecting a midwife to come around and do that test is to make sure your baby's feet are nice and warm. So you might want to put another pair of socks on them, and that goes off to a lab. So you probably remember seeing this, and if you don't, it is online. It is online if you access that website that's, where is it? On there. So that website on there, you can access all the leaflets and this as well. Screening test for your baby. It'll tell you about hearing tests for baby. And it'll also tell you about this blood spot test. So that tells you about that, because what we need your consent to do a blood test on your baby. And we like you to know what you're consenting to. Right, the other thing that I just wanted to quickly show you is on the ward you will be given one of these. This is just one I had that was an old copy that's the ring bound now. I don't know what they don't open very well. So you'll get this. It's 5 years worth of important information for babies, from vaccinations to weight. So when your midwife comes to visit you on day 5, they will, in the back there's a section there, baby's weights, measurement records. So if your midwife forgets, you can write your baby's name in there, and then we know how you're spelling your baby's name, date of birth, weight. So on day 5, when we weigh babies very often have lost a little bit of weight. We expect them to lose a little bit of weight, and the midwife will chart it on there and work it out as a percentage. Is that you, Charlie? Is that you doing all them smiley faces? Will you stop it? Will you stop it? I'm nearly done. And then there's a weight conversion there. So we will always measure your baby in grams, and then there's a weight conversion thing there to tell you pounds and ounces if you want to do it on there. So midwife will work out in a percentage what it is, and also usually visit you again on day 10 to 14, where they will weigh your baby again, and hopefully baby's now started to gain a little bit of weight, and then we would normally discharge you round about that stage, but usually when baby's back to their birth weight. And I think that is pretty much all I wanted to talk to you about. But if you've got any other questions, ask your midwife. Hi Nat, can you tell me how I can stop? So any specific medical questions? I'm not sure whether you mean any discharge in pregnancy or afterwards. So you do get some bleeding after you've had your baby, but anything that you worried about is not normal. You need to speak to your own midwife and just ask them specific questions about what's normal and what's not. If you've got any sort of real concerns about anything after your baby, you've always got delivery suites always open. Oh, Nat. So what I would suggest, if it's something that's really worrying you, you need to contact your own midwife or give them a quick call on delivery suite where they can take some more specific details from you. When I'm just, why am I, oh dear. Right, okay, so so with that, I'll leave you. If you've got any more other specific concerns, speak to your own midwife. It's right, okay. Nat, I think what I would definitely suggest is you give your local delivery suite a call. You need to get checked out. They're there for you. Yeah, Nat, you need to get checked out. You need a medical review. You need a medical check over, maybe some swabs doing and stuff like that. But you may even need a course of antibiotics. But speak specifically about certain things with your own midwife, and they can advise you on what's the right treatment for you if you're concerned. So with that, have a fabulous Friday. I'm sorry this one's taken so long, but I didn't want to rush it because I don't get the time all the time in clinic to give you guys. So thank you for being so patient with you. Look after yourselves. The midwives are here if you need anything. And you take care. All right, take care. Bye-bye.